Thank you, General Suhail. Thank you, General Suhail, for your remarks and for being with us and to kick off this session. I would now like to request our first speaker, Dr. Biljana Parapid. She is Assistant Professor of Medicine at Belgrade University, School of Medicine, and Honorary Proctor at the W. Harvey Teaching Professor at Georgetown University School of Medicine. Her research interests include coronary anatomy, in particular myocardial bridges, atherosclerosis disparities, and metabolic syndrome. She is now going to talk to us about specific cardio-oncology conditions and their complications. Over to you, Dr. Biljana.
Thank you so much. First of all, good morning to everyone, and it's good afternoon to Philippines. It's 9 a.m. here in Belgrade. Again, thanks everyone for the invite. It's always to be in Pakistan. I hope one day physically also. I started doing these virtual trips almost every month during COVID pandemic, courtesy of Professor Sumro, whose enthusiasm and energy seem to be never ending. And the only time I had to decline was just some months ago. I had a severe clinical presentation of COVID, regrettably. So I was almost for 4 months bedridden. So that was the only time that I said I'm not capable of preparing a talk in a 2-week time and share my time with you. But any other day, time of day, I'm here for you. So first of all, I would like to extend also the regards from my Madam President of the National Society, who is not from Belgrade, she's from Novi Sad. And also, since it's heart failure ongoing in Europe, my surprise speaker for you today is regrettably Madrid, because we shifted the day of the talk. So I'll be doing the cardio-oncology and show you what we managed to do in Serbia also. So besides touching up on the specific conditions that actually, so let me just share my screen for a second. I want him to show me all windows and it's not showing me all windows. So why? I'm sorry, just a second. Okay. Now let me get back to Zoom, share screen. Here we are finally. So, as we have just been chatting recently, this nice view is actually the view of the street that I still live on, and it's a piece of Belgrade that my grandmother was also street. My grandmother was also born, that I love to use to share some also my audience always with the corner of my world. So again, thank you, and also congratulations for this magnificent endeavor, because cardio-oncology, as we will see, is something that is a necessity. Actually, it's not the luxury of a medical system, it's a necessity for our patients. So when we look at the population of Pakistan right now, and this population pyramid, although I searched last night again for the current one, it claims that it's 2022, but actually these are 2016 data that I had shown even before for another talk. But we see that actually this pyramid is giving us the population that we tend to treat the most, and those are the people in the 30s, 40s, and 50s, irrelevant of sex in this particular case, because I normally should be tasked to not to talk about just women's health this morning, but I will try to stay away. So when I looked at your magnificently organized info on your Ministry of Health database that is available on the website that is shown below, the most common cancers in Pakistan, irrelevant of sex, are breast cancer, oropharyngeal cancer, and then on some 4th-5th place, we have the reproductive organs. And when we break these numbers into what women suffer from in Pakistan and what men suffer from in Pakistan, we realize actually that the leading cause in oncology substrate in Pakistan is breast cancer. And really, click here, the share the second place over there are the measure of these two, while the second one actually leading was the gastrointestinal, the oropharyngeal, sorry, which I think could be linked when I looked a bit at the data on smoking, most of men who are active smokers in Pakistan. Now, I will just take us back to 2018, two papers that are actually landmark papers for all of us who are trying to somehow introduce the concept of cardio-oncology in our own communities. And that is this is the paper that appeared in February, and it was the AHA scientific statement by Dr. Mehta on breast cancer. I will not delve further into breast cancer because I know that we have an amazing speaker on breast cancer after me. But this is actually something that reminds us of all the risk factors that we share between cardiovascular disease and breast cancer. So it's age, it's the diet, it's the family history, it's the alcohol intake, hormone replacement therapy that we often tend to prescribe to women in perimenopause if they're symptomatic. The obesity and being overweight is a global problem, whether we're talking about cardiovascular disease or any kind of cancer, or physical activity, or shall we say inactivity that is somehow the result of these sedentary lives of ours that have only grown more sedentary during COVID. Of course, not for all of us who were frontliners, but the majority of our patients worldwide became almost exclusively sedentary for almost 2 years. I think that toll we will yet to see on their health in the future. Finally, tobacco use is something that we also battle anywhere, and sadly, there's still corners of the world where we can see everyone freely smoking. But on the other side, we have also corners of the world where it's where it is pretty well restricted. So the second paper that I wanted to present first, but in the order of their appearance, it appeared in August, and this was a February paper, is the one that actually addresses the global overlap between CVD and cancer, where actually sex is the female sex in this particular case. The genetics is something we cannot get away whether we're a man or a woman. Then we have this panoply of the risk factors that are shared. Finally, the environmental exposures are also important. The infections that are mostly linked to reproductive health and education that we provide both for our children, irrelevant of their sex. Chronic inflammation that we do not always understand is present, but as the same way we know that chronic inflammations that are linked to whether we're talking about cavities in our teeth or we're talking about chronic sinus infection, and how many times I'm sure every one of you went to work with some sniffles saying, oh, I'll be fine, I will just pop a vitamin C. After 3 days, we of course very carelessly sometimes pop an antibiotic for 5 days, but that is not actually something we should encourage because the chronic inflammations of the kind carry both risk for CVD and cancer. Clonal hematopoiesis is something we cannot control. The telomere lengths we potentially could because we know that our telomeres shorten with stress. Our hormones, well, hormones, that's a big debate. We also are ingesting with lots of so-called healthy food. Why we're so crazy about healthy food and the organic produces is because they technically should be hormone-free. And our gut microbiome is something that is a new world, so to speak, for both the cancer researchers and us in CVD. Now, I'm going to use this table from Dr. Mehta's publication to actually go through the specific conditions that we end up treating together with our colleagues oncologists, or actually when we're less fortunate, actually when our patients are less fortunate, they tend to float somehow really in a very turmoil river between oncology department and our own departments. I don't know for your specific and respective hospital centers, whether we're talking about irrelevant of which city in Pakistan or the Philippines or Serbia, but our oncologies are not always in the same building as our cardiology departments. Our oncology doesn't always have nearby even internal medicine specialists to cover something that is a complication of their own treatment. So these patients, sadly, in Serbia, regrettably, we do not have a tremendously developed hospice system for patients who have advanced cancer, who are hospitalized for timely management of their cancer, but our oncology departments do not have the capacities to cover all the needs of their patients post-therapy. So when we look at this table, we understand that actually every form of left ventricular dysfunction, whether it's heart failure, whether it's just a heart failure that was concomitant with atrial fibrillation, or some kind of ventricular arrhythmia that aggravates an underlying potential for heart failure, comes actually from the point where all our patients need basically a checkup and a somehow our anesthesiologists here in Serbia love still to call it, we need cardiologist's approval. We say that it's not an approval because the approval is what the patient gets once the patient consents to a treatment or a procedure. The anesthesiologist says actually it's her or his opinion on whether something is acceptable level of risk for a procedure. But what we as cardiologists can offer is the peri-procedural or the peri-operative, and in this particular case, the peri-treatment risk for developing either heart failure, arrhythmia that might aggravate potential for heart failure based on an underlying cardiomyopathy, and of course, as we all know, thrombosis, whether we're talking about venous thrombosis or arterial thrombosis, which are rare, I agree, is something that all our cancer patients are prone to due to their baseline oncology problem. But if we focus just on the problems, we will miss our window of opportunity, and those are the solutions. And these solutions were very nicely summarized in the paper by Dr. Mikos and Blumenthal from Johns Hopkins, and that is the second paper I was mentioning, the one from August in Circulation, where actually we should stop considering our patients only our patients who don't have, as I jokingly say in Serbia, the right to have another disease. So we have to improve our bridges with our oncology departments so that they do understand that our patients are joint patients. Our patients are not just oncology patients or just cardiology patients. They're patients we share, and the better we communicate, the better their outcomes will be. And what is most important, all oncology patients, that is the quality of life. And I think that is something we will all agree. Also, a perfect moment where we can somehow screen our patients for a potential oncology problem during our own diagnostic tools is something that we should not be shy away from. As we know, if we send someone to a low-dose chest CT, it will offer us lung cancer detection, but it could be also used for CAT score or CVD risk assessment. When we send someone to cardiac CT, yes, we did send them for calcium score for CVD assessment, but it can also detect lung cancer. When we send a patient to a mammography that you have just mentioned is also an uncomfortable procedure, it can be also be a tool for assessment of CVD screening. So let's try to diminish the discomfort our patients, whether they come from our own clinics or they come from oncology clinics, suffer when we send them. So we bring into our circles in the world is the only value of our education efforts. I will share a couple of, I have recently presented in a workshop, as you can see here, this is the hashtag with which we're promoting this art center that we're opening this month in Belgrade, finally, after all the wait due to COVID, and finally also in our new space. So I was very much privileged, actually, although I was still recovering from COVID, when my students reached out to me asking to support them on an endeavor that was recently founded, and that was supposed to create peer-to-peer education so that we could work on a national strategy to lower the cutoff for screening for breast cancer for women in Serbia, because although we think young women who have access to social media and plenty of other gadgets and devices, apparently their level of education is not so high. So I present something that our local mentor there's doesn't fund. And I was the faithful, those are the investigate, educate, advocate, and legislate. Yes, this is Serbian in italics. This is Cyrillic letters. And I have actually presented how, besides the Women's Heart Center model that in our particular case has an endocrinology clinic, a medicine clinic with hematologists, rheumatologists, and immunologist referrals, our coronary circulation clinic with not only coronary artery disease patients, but also Minoka, Inoka, Mark-Crowder, Bridges, and Takotsubo. The Heart-Mind Clinic on the opposite side with SCAD patients and FMD patients that we share with neurologists, but also that accept psychiatrists and psychologists referrals. Our cardio-obstetrics clinics, I've been a guest with you on a couple of occasions talking about our cardio-obstetrics program. And finally, why we call it advanced CVD clinic, where we see heart failure, cardio-oncology, and arrhythmia patients. But because actually our cardio-oncology patients are already seen by someone who is prominent level and who sits on a bunch of guidelines. So we trained with our professor research department, and that our way of having both our Department of Cardiology and our oncology, although our clinical center doesn't have an oncology of its own, but we have a nearby building, which is actually that we service as a cardiologist, that is actually our national cancer center. So we're trying to overlap with them, the patients, and somehow transfer them. Finally, we have a lifestyle clinic because this flower means nothing without a stem. And I think that preservation of our own good health is the way to keep a healthy stem of all of us involved. Finally, what is very important, and that is something that you have managed to show that also can be done, courtesy of Professor Somro's visionary endeavors locally. And that is the same way that we have said that our Women's Heart Center shouldn't be a solitary thing. It should belong to a tertiary center of care, but it should be linked to with telemedicine to lower levels of care. But we have to educate the same way we educate our students and our subspecialty training candidates, irrelevant of the subspecialty, to the sex-specific differences of coronary artery disease. This is the same way we should remind also our oncology, gastroenterology, abdominal surgery residents and fellows that all these patients also happen to have a heart. Yeah? So our research, we know that our epidemiological research hasn't been so much financed globally, but that is something that we should work on. And finally, the advocacy that you have also shown beautiful in Pakistan offers the possibility of partnerships. And I'm not fully sure whether your own healthcare system is fully government budgeted. Ours is. It also opens a window of opportunity for companies who are present, or foreign companies who are present in the market, to invest in something that is social responsible behavior. Finally, this is Dr. Wenger, just during ACC. This is Associate Professor Maria Zdravkovic, whom I wanted to introduce to you today as a surprise speaker, because she is not only an amazing WIC who is running a hospital center that is also one of the affiliated hospital centers of our Belgrade University, but the center that she's running is actually our leading breast cancer institution, and her program for women who have breast cancer over there is something amazing that I wanted her to share with you today. But sadly, because she's in Madrid and her at heart failure, also giving a talk this weekend, this shift of the date, which I dated, a bit ruined the surprise. But I am sure that in the future we will also be able to include her, as we have tried with Professor Sommer to always introduce another speaker. That it's not, of course, always me, but there is someone else that I can always sit on the panel, which I gladly do. So these are my students who have shown these brilliant endeavors. This is our Minister of Health. This is an event that we held recently in our Ministry of Health, and this is from one of our weekly meetings. This is the packed room for the cardio-oncology and women's health workshop that we held. And I will close just with inviting you all, whoever can join us tomorrow night. It is under the auspices of the Saudi Arabia chapter of the American College of Physicians. And we'll be talking about women's health again. I will repost this because with the link, because I'm missing here a link for where you can register, where you can listen to us. It's going to be 7 p.m. Saudi Arabia time. So it's going to be it's going to be 9 p.m. in Pakistan, or am I wrong? Can someone correct me? Okay, you'll correct me at the end.
Yeah.
So
probably.
as I usually say, it doesn't matter where we are trained. I was also trained in I come from a country that is Orthodox Christian. I am Greek of origin on both sides of my family. My mother's side, I'm 5th generation Greek, raised in Serbian and Greek. My last name is also Greek because my father's family was originally Greek and ended up in Montenegro fleeing from the Turks. And you know, when Turks were coming to the Balkans, it was another century. I was also trained in an institution which is a Catholic and Jesuit institution, but we have to bring the best of the institutions that we were trained and embrace the cultures of other people for the benefit of our patients and actually our own. And cura personalis is treating the whole person. And that is also one of the mottos actually of cardio-oncology when you look at it, because you cannot treat any cancer without treating the heart, and you cannot treat cancer without treating someone's family and their own response to psychological response to the trauma of the disease itself and their lack of quality of life impact on their families. And with that, I say thank you, but someone has to teach me how to say thank you, Lord.
Thank you very much, Dr. Biljana Parapid, for a fascinating lecture. This was
Thank you
really
so much. I'm just trying to close this thing of mine. Here it is. Stop share. Good. I see you now.
Fascinating lecture and a great peep into the Serbian health service. And I love your last slide, which says that we have to look at the patient as a whole. And I think in this era of super specialty, doctors do not wish to take the responsibility of the whole patient. They just want to look at that particular organ and shelve the responsibility essentially. So I think fascinating. I think we'll take a panel discussion and questions and answers at the end. So stay with us. Let's talk through let's get through the rest of the talks as well. And then we will take that on. Fascinating. I have learned so much today. I hope everyone else has as well. We will now move on to our next speaker, who is Dr. Lubna Bakai. And she will be talking about the role of biomarkers and cardiac imaging in early diagnosis of cardiotoxicity. Dr. Lubna Bakai.
Thank you, Dr. Amber. I am here. Audible or not, please?
Very well, thank you. We can see you and we can hear you. Let's have your slide.
First of all, I am very thankful to the Pakistan Cardiac Society and especially Dr. Khalda Sobro for taking such a great initiative. As we all know, it's an evolving field that is most ignored and leads to the increased morbidity and mortality, especially of the breast cancer survival patients. Now, I would like to start my presentation, especially focus on the cardiac biomarkers in imaging in early detection of cardiotoxicity in the field of the cardio-oncology. So where is the gap? So I would like to start my talk with a case of a 45-year-old female that is hypertensive and treated for the CA breast around 1 year back. Now presenting with a severe exertion, shortness of breath, and the features of congestive cardiac failure. The piece is
sorry to intervene. Do you have slides to share? Do you have slides to share?
Okay.
Yeah, please share their slides.
I have to share my screen.
Yes, please press on share screen, which will be at the bottom of your Zoom bar, and that will guide you further.
Sorry, just a minute, please. A couple of minutes, please. Now is my screen shared?
No, we can't see your screen share. It should say share screen, and then press
Yeah,
on
I'm
the
clicking with press.
when it says share screen, then there will be on the top, there will be saying start share screening. You have to press that button also. Do you need help for this?
Yeah, I am pressing the share screen, but it's not doing. I don't know what's happening here.
Actually,
Just
Dr.
please,
Lubna,
couple of minutes.
it has to offer you, it should offer you a screen that you want to share once you click that.
Now share?
Yes.
Oh, yes, excellent, excellent. Now you just open your presentation, yeah.
Yeah.
Sorry.
Excellent.
Now I'd like to start my presentation of the cardiac biomarkers and imaging in the early detection of the cardiotoxicity in the field of the cardiac oncology. So where is the gap? Now I would like to start my presentation with the case of a 45-year-old female that is hypertensive and was treated for the CA breast around 1 year back. Now presenting with the exertional dyspnea and the features of the congestive cardiac failure. Now the images is clearly evident from all the echo windows that is the severe LV systolic dysfunction. Not only the severe LV systolic, but you can see the RV is also severely reduced. Both atrias are dilated, means the gross heart failure because of the cardiomyopathy. Now, where is the gap? Can we prevent this landing up of these cancer survivors from these cardiomyopathies and heart failures? Because if we protect these from the cancer but end up with these cardiotoxicity, there is no mortality benefits for these patients. So I like to properly start my presentation. As we all know, this the advancement in the chemotherapeutics leads to the increase in the cancer survivors that are with the cardiotoxicity. The pre-chemotherapy cardiovascular risk assessment is very important. If we classify these patients from the low to high risk patients, then we can better plan for the frequent surveillance and the prevention of these lethal complications. The selection and role of the biomarkers in the early detection, and then the various imaging modalities for early diagnosis and the follow-up. As Dr. Virginia very well said, that it is a collaborated approach between the oncologist and the cardiologist. Being as a cardiologist, I don't have much understanding about the various complications of the chemotherapeutics. But as a cardiologist, I can know how to investigate this patient, how can prevent, how can we treat these complications. So first of all, we must collaborate not only but to educate each other. The cardiovascular risk stratification before start of the chemotherapy, then the cardiovascular toxicity monitoring plan must be in before the chemotherapeutics. The cardioprotective treatment, when to start, and the decision to continue, interrupt, or the restore cancer treatment. And these patients must be have a long surveillance plan, as late complications can occur even after the years. So broadly classify the low risk, medium risk, and the high risk patient. In the low risk, we don't need the frequent screening. These are the usually 18 to 50 years old patient with no cardiac risk factors. Medium risk are those with the moderate risk, moderate doses, and with the age 50 to 64 years, and the 1 to 2 cardiovascular risk factors. In the high risk population are those who have the combination of therapies or the higher dose or with the radiotherapies, and with the age of the 65 and more than two cardiovascular risk factors. This is the slide where they especially focus on the high risk patient. Because these are the patients that must screen and do the surveillance more frequently. What are these patients? The high dose anthracyclines, the high dose radiotherapy with the age more than 60 years, or the low dose radiotherapy with more than or equal to 2 cardiac risk factors. They're including the smoking, hypertension, diabetes, dyslipidemia, chronic renal insufficiency, obesity, or the patient has the previous underlying heart disease, whether the valvular, whether the coronary artery disease or hypertensive heart disease, elevated cardiac biomarkers before initiation of the anti-cancer therapies. What are the various biomarkers and why are these used in cardio-oncology? The biomarkers are used in cardio-oncology for the diagnosis, for surveillance, for risk stratification, for guiding the treatment plan, and monitoring the response to the therapy. And what will be the characteristics of the ideal biomarker? Because we all know that the various biomarkers not only released by the myocytes, but can also released by the many other organs. And in chemotherapy, there's the lysis of the many other organs, tissues. So these biomarkers used for the surveillance must be sensitive, means released by the cardiomyocyte, and must be specific, and that can be released by the myocyte and sensitive so that they can pick the very early disease. Stratify the risk of progression. That must be cost effective. It is a main issue in our population, and must have help in the personalized management plan, must be quantifiable, and must correlate to the clinical outcome. So which biomarkers fulfill all these criteria? As the most literature supports the use of the cardiac troponins and the natriuretic peptides in the use of the cardiac disease monitoring and prognostication. So these two are frequently used in the cardio-oncology also, where chemotherapeutic drugs have implementation of the biomarkers differently. As we all know, the anthracycline in acute and early onset release cardiac troponins more than the natriuretic peptides, whereas the late onset natriuretic peptides more than the troponin. In immune checkpoints, both equally and HER2 targeted therapy, nitroproteins more than the cardiac troponins. The most important things in doing the surveillance of these patients, there's the same biomarkers must be used for the follow-up, for the seeing the progression of the disease. As different companies have the different reference values, so the same biomarkers must be used for the follow-ups. Other main causes of the proper release in cancer patients can be acute coronary syndrome, as we all know, the anthracycline related, pulmonary embolism, various tachycardias, pericarditis, Takotsubo, and the high demand supply mismatch can also cause the release of cardiac troponins like anemia, hypertension, sepsis, and acute rise. Direct myocardial infiltration can also cause the release of the cardiac troponins. How we do the surveillance? The different chemotherapeutics have the different frequency plan, but broadly we can classify as we should do baseline in all the patients, whether low, medium, or high risk. In the low risk, we needs less frequent follow-up, and in the high risk patient needs more frequent, like before every second, fourth, or sixth cycle. Even every cycle we can do this. And after completion of the chemotherapeutics must be followed for the long term. In the low risk patient, less frequently after the year, and in the high risk patient in 3 to 6 months and more frequently. HER2 targeted therapies, BNP, nitro-BNP, and troponin both. Baseline must be do in all the groups. In the high risk, do more frequently. And these must have the surveillance long term after the completion of the chemotherapy. The important thing is that the baseline should be done in all the patients who have the previous ancestral cycle. I will not discuss about a metastatic disease as this patient has the poor outcomes. Or for the vascular endothelial growth factors, BNP is more reliable biomarkers for use as cause the heart failure. Baseline in all the patients, in the high risk patient, 2 to 4 weeks after starting treatment and after 3 months during the treatment. In checkpoint inhibitors, you do have to do the ECG, troponins, natriuretic peptides, and echocardiography in all the patients. During surveillance, we use the every 2 to 3 and 4 dose. But if our patient have the cardiac symptoms, because immune checkpoint inhibitors can cause the acute myocarditis that can lead to the permanent heart failure. So if any new cardiac symptom develop during any stage of the chemotherapeutics, we must repeat the cardiac biomarkers as well as the imaging and refer this patient to the cardio-oncology specialist team. Now I'll come to my imaging part. I will try to complete into the 10 minutes talk. What are general principles of imaging? The imaging, the echo is the most important tool. The 3D is the ideal standard, but unfortunately not easily available at all the centers. So when we are doing the 2D, we must do the biplane Simpson method for the objective evidence. So because they will be the variability in the visual estimation. Try to do the major LV volumes. Consider CMR in difficult cases when there is a poor echo windows. Always combine the imaging and with the biomarkers and the clinical data. Always measure the blood pressure because the filling pressure, hemodynamics can alter the various parameters during the echo. Always try to measure the global longitudinal strain. It's a very important tool for early detection. Why we are doing the imaging in these patients so frequently? For the screening, for the risk stratification, and for the early detection. Detection of the subclinical LV dysfunction. How we define the chemotherapeutics related cardiac dysfunction is defined as a decrease in the EF of more than 10% point to an absolute value less than 50% by echocardiography. But the important thing is that these decreases should be confirmed by repeated cardiac imaging. How we repeat? Usually 2 to 3 weeks apart when the initial decrease in LVEF has become evident. The further categorized as a symptomatic, asymptomatic, and regards to the reversibility. What in various imaging modalities? The most important is the echocardiography, MOGA scan, nuclear imaging, less frequently used, CMR, and the CT scan. I will discuss later on. Echocardiography is a method of choice. Calculation of LVEF ideally must be done by the 3D echocardiography, but unfortunately not available in many of the centers. Very time consuming, needs expertise. So we are using the 2D echocardiography. If we are doing the 2D, we must do the modified biplane Simpson technique or the auto EF when many companies available. The use of LV contrast when there is a poor demarcation of the endocardial borders. Use of strain imaging for early detection. Strain is a very good modality because before the EF decrease, strain start to reduce very early in the involvement of the myocardium. By echocardiography, we can also diagnose the simultaneous valvular, diastolic, pericardial, and can be assessed. Which parameters can we use for the cardio-oncology surveillance? LVEF by the 2D Simpson, and ideally must be by the 3D, global longitudinal strain, and the systolic and diastolic volumes. Other important thing, RV function must be assessed simultaneously, the velocity of TR for the identification of the pulmonary hypertension, the IVC size and collapsibility for the volume status. And many patients, the LVEF is reduced, but volume status not much high. So we have to decide about the diuretics use or not on the basis of the volume status on the echo. We are doing 3D echo at our center at Tamar Institute. It's a very good modality and can best correlate with the CMR. By 3D, we can accurately measure the LVEF. As in biplane, we have only 4 and 2 chambers, so we can miss the LVEF in the 3-chamber views. By doing the 3D, we have a triplane LVEF that correlates well with the CMR. 2D echocardiogram is a very good modality in the patient which have the good echo windows. Always try to look into each and every window and measure objectively with the biplane EF for the future follow-up and monitoring. Strain is a very good modality. On my right hand, this is the average longitudinal strain, about -19 is normal. -20 plus -3 is a normal value of the average GLS, but it's very from different vendors. From one GE to Toshiba to Siemens, these have the different cutoffs for the normal. But we are using the G software and the Tabahart, so it's -20 plus -3 and the reduced, -3 mildly reduced and the severely reduced. How we are doing the echo and how frequently. In the low risk patient, we need to do less frequent imaging, but in the medium to high risk patient, either every 2 cycle or can even consider after every cycle if the patient is high risk. Following chemotherapy must be done in the high risk patient 6 months after the final cycle, then 12 months, then should be screened annually for the 2 to 3 years thereafter. This is very important because anthracycline, we can have the very late onset cardio toxicity and the heart failure. And we have seen many patients who are survival of the breast cancer presenting very late with the heart failure. HER2-targeted therapy, same baseline must be done in every patient. In the low risk, every 4 cycle. In the high risk, every 2 cycle. And then can reduce every 3 if it's stable for the 3 months follow-up. And afterward, 3 to 12 months. Now, other modalities where to use and why. The MUGA scan used by the many centers for the LVEF when the echo windows are not adequate, but limitation because of the high radiation exposure, lack of ability to report on the pericardial and valvular heart disease, and other diastolic filling pressures and the RV functions. Gamma camera is not routinely used, and there are no major study reproducibility not well known. CMR is a very good and gold standard for the imaging. But its main limitation is that it's limited availability and its cost. In our population, cost is the main limitation because CMR is very expensive. We cannot do more frequently follow up these patients. But when the echocardiography and nuclear imaging are inconclusive, because in many patients we have the surgeries, best resections, and various thoracic surgeries, infiltrations, so echo windows cannot be optimal in such patients. So in these cases, when we have a doubt, these are high risk patients, we can use the CMR. CMR, very good image resolution. We can accurately measure the LVEF. So it's a gold standard, but on the echo 3D can well correlate with the CMR. CT scan, when to use the CT scan is used for the surveillance of the coronary artery disease when we have the suspicious of the simultaneous coronary artery disease, and we have to rule out the ischemic cardiomyopathy, then we can use the CT coronary angiography in these patients. Suspected pericardial involvement can also be ruled out. For metastatic disease, they can use the CT scan. CT coronary angiography is a very good modality when we have to rule out the concomitant coronary artery disease. Pericardial involvement can be easily seen on the CT. Now, at the last, I would like to share with this recent Pakistan Cardiac Society guideline for imaging in cardio-oncology under supervision of Qadir Somro and Dr. Sultana Habib. I contributed this part. So, you use echocardiography, 2D, 3D, and strain CMR in the poor echo windows patient during chemo and post-chemo. As these are usually focused on the female breast survival patients, so I major emphasize on the anthracycline and the HER2 receptors targeted therapies. Low risk every 4 cycle, in high risk or intermediate risk patient every 2 cycle or even every cycle can be do. In the CMR in the patient who have the poor echo windows. Now I would like to end my presentation with these take-home messages. CRTs can be prevented when identified early. There must be the corroborated evaluation by the cardio-oncology team. We need to develop such departments in various oncology units also. Timely use of ideal biomarkers can pick very early cardiotoxicity, cardiovascular imaging, need for timely diagnosis for the cardiotoxicity. Strain imaging and 3D volumes are the optimal techniques, and we try to incorporate in our echo studies wherever possible. CMR in patients with inconclusive echocardiography, when we have to decide whether chemotherapy has to be continued or stopped, and we have the poor echo windows, we can use the CMR as a modality. The intensity of biomarkers in echocardiographic monitoring should be based on the type of therapy and the individual risk of the cardiotoxicity. So there must be an individualized plan for every patient, whether in high risk or low risk, and then plan for the frequency of the intensity of the biomarkers and imaging modalities. And as Dr. Biljana said, this is the problem, and we need to sort out the solution. So there are further studies needed, more funding needed to develop a strong evidence, to develop a risk score or the protocol for monitoring these patients. Now I'd like to end my presentation with this cartoon. Oncologists and cardiologists both are too busy, but we need to develop new tools, new studies, new research to help our patients and monitoring these patients. Thank you very much.
Thank you very much, Dr. Lubna Bakai. This was great. I truly enjoyed it. I think we will have a lot of questions and a lot of comments from our panel, I'm sure. So I would suggest to all that you write down your points so that we can come back to them speaker by speaker and come back at the end of the 4 talks that we have. We're really nicely building up on this theme as we go along in our talk. I'm having a great time. I'm sure everyone else should also be.
Thank you.
So let's move on to our next speaker. Thank you very much, Lubna. This was really great. I truly enjoyed it. Loved your pieces. So let's move on to Dr. Nanette Ray, who will talk to us about heart failure and cancer, and will be particularly about breast cancer. And let me give a short introduction for her. She is assistant professor at De La Salle College of Medicine at the De La Salle Medical and Health Services Institute. She's head of electrophysiology unit. She's the medical director, Silang Specialists Medical Center. She's chair Department of Medicine at the Tagaytay Medical Center, Philippines, and she's head of intensive care unit. So I think somebody, and she's a member of the residency training committee, member of the e-learning committee, and with such a wide spectrum under her, let's be all ears for her talk on heart failure and breast cancer.
Thank you very much. Thank you very much, Professor Malik. It's a great pleasure to be here. And of course, I'd like to thank the Pakistan Cardiac Society and my dear friend, Professor Khalida Sumro, for inviting me once again. It's the same with Professor Parapid. We've been here for several times already over the past pandemic. And it's always a pleasure to be able to talk to you with regard to some special topics, particularly with the women. Okay, so this will be, can you see my slides?
Yes, we can. Thank you.
Okay, thank you very much. And so this is my assignment for today: breast cancer and heart failure. Is it really success or failure? And if you look at it, my job has become much easier because Professor Parapid and Professor Bakai came before me and have already explained a lot of the items that you need to know with regard to cardio-oncology and of course the imaging and the biomarkers. So I'll just be touching a little bit on this item. So it will basically be focusing on breast cancer and heart failure. Now, if you look at WHO top cause of mortality, ischemic disease remains the #1 killer, and in 2019, the data shows about 8.9 million people died from ischemic heart disease. And for cancer patients, if you look at more recent data, ischemic heart disease, again, is still the top cause of death, because right now, with improvement of treatment for cancer, there is longer survival for these patients. So more of these patients are developing cardiovascular diseases, and this diseases have already become the mode of exit of these cancer patients. Now, this is the top causes of mortality in the Philippines in 2019. And I also looked at the data in Pakistan, and they very closely mirror each other. For the Philippines, the number one killer is ischemic heart diseases, and number two is malignant neoplasms. And I just looked also at the data from Pakistan, and the number one killer in Pakistan is also ischemic heart diseases, followed by malignant neoplasms. And particularly, if we're talking about women, it is mostly because of breast cancer. Now, Professor Parapid already looked at and explained to all of you with regard to the relationship between cancer and heart failure, and that there are a lot of pre-existing risk factors that predispose patients to develop cardiovascular disease and have also been noted to be risk factors for the development of breast cancer over time. As a backgrounder, older women with hormone-positive breast CA are more likely to die from cardiovascular disease than from breast cancer. And common risk factors for both, and this has been elucidated very clearly earlier, would include obesity, smoking, excessive alcohol use, diabetes, hypertension, metabolic syndrome, unhealthy diet, and physical inactivity. In fact, it has been shown that hypertension has been linked to increased incidence of cancer and cancer-related mortality. And when you're talking about cardiovascular events in women, if women have optimal risk factor profile at 45 years old, the incidence of cardiovascular events is just about 4.1% as compared to a 20.2% in patients with one major risk factor. Now, let's look at the breast CA and heart failure per se. Now, patients with diabetes, obesity, and metabolic syndrome can have elevated levels of carcinogenic hormonal mediators like insulin growth factor 1 and estrogen. And this one actually, or these items can increase the risk for breast cancer. So you see the very close relationship between cardiovascular risk factors and the incidence of breast cancer because of common mediators that occur in both conditions. Hence, it's very important that if we're treating patients with cancer, we have to optimize their cardiovascular disease risks. Those patients with CVD risk factors must undergo enhanced cardiac surveillance and prevention program. And cardiovascular disease prevention has been noted to be associated with a lower incidence of cancer and actually may reduce the lifetime risk of cancer. Before we never thought that there's a very close relationship between the two, but now we are seeing that very, very close relationship between the two, that patients who are at increased risk for cardiovascular disease are also at an increased risk for cancer occurrences, and that if you optimize these risks, you may actually reduce the lifetime risk of cancer for these patients. Now, the other issue is that what about treatment per se? Because it's not just that cardiovascular disease risk will increase the risk for cancer and increase the risk for cardiovascular disease, but even treatment or multimodality therapies for cancer can actually make patients more susceptible to asymptomatic LV dysfunction and clinical heart failure either during and after treatment. And in fact, if you have a new or pre-existing LV dysfunction, this can also lead to interruptions in cancer treatment and limit our options for cancer systemic therapy and lead to adverse outcomes. Right now, if we're looking at breast cancer systemic therapies, the most commonly used agents are anthracycline and trastuzumab, and these are both cardiotoxic treatments for cancer therapy, and that has been shown earlier by Professor Bakay. Now, in fact, your anthracycline is a potent inhibitor of topoisomerase, which affects the DNA function. And when we're talking about cardiotoxicity, this is actually dose related. So the higher the dose of the drug, the higher chances that you can have cardiotoxicity. And when we're talking about cardiotoxicity, this can range from asymptomatic LV systolic dysfunction to overt heart failure. Now, the use of anthracycline has declined over time because of the resultant cardiotoxicities that have been encountered in the past. But this remains to be the treatment of choice for certain types of breast cancer. And the current doses that are recommended right now are in the low doses, which is around 240 or less than 250 milligrams per meter square, versus the previous dosage, which is usually 300 milligrams per meter square, which has a much higher incidence of cardiotoxicity compared to the lower dose. For anthracycline, the risk is higher for women more than 65 years old. And in fact, patients receiving anthracycline-based therapy show about subclinical LV dysfunction in approximately 10 to 50% of these patients. Now, trastuzumab, on the other hand, is a human epidermal growth factor receptor 2 or HER2 antagonist, and it blocks the overexpressed signaling pathway in HER2 positive breast CA. Now, it has dramatically improved the outcomes in HER2 positive metastatic breast cancer with improved overall survival. And this actually happens when you add it to doxorubicin-containing chemotherapy. So these are usually used in combination, either together or as a sequential treatment, or you start first with doxorubicin-containing therapy before following it with trastuzumab. Now, the thing is, because both drugs can potentially cause cardiotoxicity, approximately about 27% of these patients would develop cardiomyopathy and heart failure. And so safety measures that have been done include separate administration and close follow-up in monitoring the LV ejection fraction of this patient. And it is recommended that you cease treatment or you stop treatment if there is significant reduction of your LV ejection fraction, which is about 10% reduction in LV ejection fraction. Now, what are the things that we need to consider for treatment for these cancer patients who might be potentially having cardiotoxic complications over time? The most important thing always is to look at the thorough patient history and physical examination of these patients and identify the baseline cardiovascular risk. It's very important to identify the presence of LV dysfunction or the presence of clinical heart failure or those with heart failure stages C and D, or see patients who have ejection fraction less than 40% with stage C or stage B LV dysfunction. And these patients are the ones who are actually not recommended to receive anthracycline-based regimens because of the higher risk of having subsequent reductions in the ejection fraction. Now, if a patient has a 40 to 50% ejection fraction, they may still receive the treatment with anthracycline and trastuzumab based on the tumor burden and if the benefit outweighs the risk of cardiac dysfunction. Otherwise, if these patients would run the highest risk of having heart failure over time, then it would be more prudent to look for other possible alternative treatments for this patient. Now, when do you see high risk for cardiotoxicity? This was already shown by Professor Bakay earlier. When you're using high dose anthracycline, so that's doxorubicin more than 250 milligrams per meter square, or epirubicin more than 600. If you're using high dose radiotherapy, that's greater than or equal to 30 gray, especially when the heart is in the treatment field, or when you're using low dose anthracycline with low dose radiotherapy, but where the heart is in the treatment field. And you can also have a higher risk of cardiotoxicity when you treat with lower dose anthracycline followed by trastuzumab as seen in sequential therapy. Other conditions would be for patients treated with lower dose anthracycline or trastuzumab alone in the presence of the following risk factors, and this has already been elucidated also earlier. If your patient has equal to or more than 3 cardiovascular risk factors, which include smoking, hypertension, diabetes, dyslipidemia, and obesity. If a patient is more than 60 years old at the time of cancer treatment, and if there is compromised cardiac function at any time before or during treatment, or when a patient has a borderline ejection fraction of 50 to 55% and a history of myocardial infarction or moderate valvular disease. Now, primary prevention, very important in order to minimize the risk of your patient having cardiotoxicity from cancer chemotherapy. Very important to risk stratify these patients and identify potential treatment in high-risk patients. Now, your RAS blockers, your ACE inhibitors, and ARBs may possibly protect against early decline of LV function. In fact, it has been shown that for hypertensive patients, treatment with cancer, no hypertensive patients with cancer, treatment with RAS blockers or beta blockers can help delay early decline of the ejection fraction of this patient. On the other hand, you have the Manticore trial, which looked at trastuzumab-mediated decline in ejection fraction, and it was shown to be attenuated with bisoprolol versus perindopril and placebo. Yet, there are some studies which did not show significant difference of beta blockers compared to placebo. However, there was another study which showed that troponin I was seen to be lower in a study comparing carvedilol to placebo when they undergo chemotherapy with these agents. Statin has also shown to be significantly helpful in, in patients with reduced heart failure compared to propensity matched controls. Other condition, we mentioned with regard RAS blockers and beta blockers, although there are some data to show that they can potentially be helpful. Currently, there are no definite cardioprotective effects at this time because of the conflicting results of studies. But there are still a lot of studies that are ongoing right now, and we hope that over time, we will be able to get more information with regard to the potential use of these agents as a possible prophylactic agent for patients undergoing chemotherapy for breast cancer using cardiotoxic agents. What about surveillance? This was also mentioned in detail by Professor Bakay earlier. When we're talking about cardiac toxicity, this is defined as a decrease in ejection fraction greater than 10% to a value below the lower limits of normal LVEF or a value less than 50%. So if there's a 10% decline in the ejection fraction and the EF drops below 50%, then this is one definition that confirms there is cardiotoxicity that is happening with chemotherapy. And the current American Society of Echocardiography expert consensus also included global longitudinal strain and cardiac troponin I in the risk stratification of patients before and during chemotherapy. So for surveillance, other potential biomarkers, this has been discussed very extensively earlier, your natriuretic peptides, your cardiac troponin I, looking at your LV remodeling in echo and the myocardial strain. And it has also been mentioned that troponin I's may actually detect cardiotoxicity at the preclinical phase of treatment in these patients. Strategies for surveillance, of course, we have emphasized this several times already. Baseline assessment of cardiac function is very important to identify these patients who might be at higher risk of cardiotoxicities. Now, it's very important to initiate effective therapies in the presence of abnormalities and reassess the LV function within several weeks, especially when you have onset of symptoms. So testing again or retesting for this patient, especially with imaging and determination of biomarkers are primarily driven by symptoms. So if you have symptoms occurring in these patients, this becomes an indication to do another testing to see if there are complications that are happening. Now, if low-dose anthracycline treatment is being used, usually no further imaging is needed after the completion of the treatment. However, for those with high risk for toxicity, it is recommended to have repeat imaging at completion and in 6 to 12 months thereafter. For those receiving cumulative doses of anthracycline, more than 255 milligrams per meter square, it is recommended to do imaging prior to each additional 50 milligrams per meter square additional dose of the drug. And imaging every 3 months during the first year of treatment is actually recommended for HER2-targeted therapy in early breast CA or lifelong, meaning every 3 months lifelong for patients with metastatic carcinoma. Now, for cardiac dysfunction, treat according to the heart failure guidelines. So we have the heart failure guidelines that would tell us how to approach these patients, and you have the pillars of treatment for heart failure, which are readily available and have been shown to be very, very effective. Right now, however, when it comes to cardiotoxicity from chemotherapeutic agents, there are mixed results. Some have reported complete recovery. Some showed no recovery at all, and a percentage of patients have shown partial recovery over time, now over the next 3 to 5 years. So the key takeaway messages for this afternoon is that heart failure during or after breast CA therapy is a growing concern. Cardio-oncology is a new, relatively new field that is becoming very interesting at this point in time. So for patients who are undergoing, breast CA patients who are undergoing chemotherapy, it's very important to have a thorough history and physical examination to identify the patients who are at risk for developing heart failure complications with cancer therapy. Cardiotoxicity, please bear this in mind, this is usually dose related. And so therefore, we try to stick with low doses of the drug to minimize the risk for cardiotoxicity. Very important would be to monitor the symptoms of possible onset of heart failure in patients who are undergoing chemotherapy and identify these patients early to allow for early initiation of therapy. And cardiac protection therapy is currently evolving, and we hope that over the next 5 to 10 years, we will have better treatment that can be given to protect the hearts of these patients undergoing chemotherapy. Now, cardio-oncology, we already mentioned this, is a growing field that's primarily aimed at early identification of cardiac complications of cancer therapies. And tools to detect early cardiac complications of chemotherapy are also evolving. Cardioprotective drugs are very important and currently under investigation to hopefully improve the prevention of chemotherapy-related cardiac complications. And again, cardiac toxicity definition is also evolving in order to allow early detection of subtle LV changes to promote safe and effective use of chemotherapy to ensure the best outcomes for these cancer patients. And with that, I'd like to thank you for your attention.
Dr. Nanette Ray, beautiful presentation, and as with the previous speakers, opens a whole field of questions and answers, a lot of conversation in my head. I have jotted down some questions and some comments, and I'm sure so has everyone else. A great talk, and we will come back to you with questions and comments in about another 10 to 15 minutes. Because there's a lot to talk about on treatment and where we are all confused. May I move on to the last speaker of the day, who is Dr. Iram Niaz from the Pakistan Atomic Energy Center. And I must say, having looked through her CV, she's an amazing person who is now, who is an FCPS in gynecology, as well as certification in the Board of Nuclear Cardiology. And a very interesting combination. Over to Dr. Iram Niaz for her talk on cardiovascular toxicity related to cancer treatment.
Thank you so much, Dr. Amber. I'm feeling very good to see here all of you people, the legends of cardiology. Are you able to hear my voice?
Very nice. We can see you very well and we can hear you very well.
Okay. Now I'm going to start my presentation and I'm sharing my slides. My slides are visible?
Yes, coming through.
Okay. So I'm really thankful to Go Red for Women and Pakistan Society of Cardiology, and particularly Madam Khalda Sumro. She is really legend and she is an example for all of us. You know, when I started to talk on the cardiovascular toxicity related to the cancer treatment, in March, Madam has arranged a program at the Sakhar, and my friend has called me that you have to represent your institute. Then I decided that I should take a part in the cardiovascular toxicity related to cancer treatment, because most of the time when I search on the search engines, I found a very minimum data on the cancer treatment related to cardiovascular toxicity. And at that time, Madam appreciated me a lot, and she said, this is the time that we should take a baby steps for the cardio-oncology start of that theme. So I'm really thankful to Madam Khalda that she took a best step and collect all the legends over this platform. So can I say the sentence of the day? Cured cancer patient of today does not want to become the heart failure patient of tomorrow. Is it right? So oncology, the dramatic advances in both the diagnosis and treatment of cancers have occurred in our lifetimes. These advances have led to improved survivorships. And you say, is my other speakers, they have given a lot of ideas related to the start of the complications and cardiotoxicity. They make my presentation very easy. I just want to give a brief and thorough idea. So in USA National Cancer Institute estimates 30.7 million cancer survivors alive in 2012. This number will approach 18 million by 2022. 67% of adults diagnosed with cancer today will be alive in 5 years. 75% of children diagnosed with cancer will be alive in next 10 years. With improved survivorship has come a startling fact. After surviving cancer, patients are more likely to die heart failure, so heart disease and cancer are the two major causes of morbidity and mortality worldwide, accounting for at least 70% of the medical reasons for mortality across the globe. You know what cardiac drugs in oncology play a major role is already other professors has also given a lot of inputs over these drugs. This is just a simple brief idea that a lot of drugs which may lead to heart failure and myocardial dysfunction, like doxorubicin, epirubicin, liposomal adriamycin, cyclophosphamide, ifosfamide, docetaxel, bevacizumab, trastuzumab. So these all actually targeted therapies because as advancement goes on, lot of therapy agents has been diagnosed and research is going on. And in this way, we can be able to be on the safe side to prevent the cardiac damage in later life. Cardiovascular adverse events of anti-cancer agents, they may lead to myocardial dysfunction, heart failure, myocarditis coronary artery disease, QT prolongation, systemic hypertension, thrombotic disease, arrhythmias, myocardial infarction, and valvular disease. What is the definition of cardiotoxicity? And what type of cardiotoxicities due to the anti-cancer drugs? The most commonly used definition in clinical practice and clinical trial is left ventricular ejection fraction decreases more than 10% to below 50% with or without symptoms of heart failure. You know, the most commonly drugs which can be counted in the chemotherapy, the basic is the doxorubicin. As we all know, the common disease in the females are the severe breast and malignancy, and currently worldwide, the ischemic heart disease seen on the top, while in Pakistan, the same observations, the severe breast is on the top, but before that, ischemic heart disease. So mechanism of action which leads to the cardiac cell death or cardiac dysfunction. Actually, doxorubicin leads to the oxidative stress and which lead to damage and vicious circle has been started and no reversibility has been found after the stoppage of even chemotherapy with the doxorubicin. While with the targeted therapies, this can be reversible because they leads to the cardiomyopathy and cardiac dysfunction. See the iceberg. Have you observed over the surface of the sea, just 10% of the iceberg has been seen, while the depth is 90%. So this is the same scenario which is correlated with the chemotherapy drugs. When we give the chemotherapy, we think this is just a treatment of the tumor, but we don't think the depth of the drug, what it leads to. It may cause damage from head to toe, but particularly with the cardiac damage means end of the life. So at which level we need to screen, at which level we need to stop, at which level we need to select the cardioprotective strategies. So this is just a simple way of the mechanism, how the cell dysfunction, how the necrosis, how the apoptosis has been occurred with the anthracycline. I will not go into detail because time is short, but these are actually the baby steps we are taking. The next time, inshallah, we will take major steps and we will go in detail of the each topic and each presentation. Is Dr. Bakai also elaborate the diagnostic tools and biomarkers? So I will not go in detail. These are just echography, mega, cardiac MRI, cardiac biomarkers, troponin T, and brain natriuretic peptide. When it becomes rise and when it becomes normal, the oncologist as well as the cardiologist should be keeping this thing in mind, and they should allot. It's my request to all the panel persons that they should keep this in mind and play a major role to develop collaboration with all oncologists, and I will play a bridge in between. So why not we think about the birth of cardio-oncology? Currently in European countries, many of countries are running the cardio-oncology clinic, but where we are, we need to think about this. So a clinically based discipline focused on the cardiovascular health of cancer patients and cancer survivors. Why the cancer survivors has been observed the prolonged life, or they are even enjoying their life because of the best cancer care support, best treatment options. So again, I must say the first word for the first sentence, the patient of cancer don't want to, they don't say, they didn't think that they will die with the cardiac disease. So what does a clinic offer? They offer a best access to the cardiologist and understanding systematic and targeted therapies and provide the best care. So today is the time that we need to develop cardio-oncology partnership. So I must request all of the cardiologists that they may develop the partnership with the oncology institutes of the Pakistan and even international basis. So come to the point, a cardio-oncology expert panel from the French group. Cardio-oncology was composed of cardiologists, oncologists, hematologists, pharmacologists, and expertise in cardio-toxicity. They analyzed and compared the key components of the pathway recommended by the recent guidelines from American and European societies of both oncology and cardiology. They proposed a practical approach. Then if every oncologist, every cardiologist follow these guidelines, definitely we can handle our patient with full of care, full of love, and we will take as a patient as a whole. As Professor Biljana said, that we need to take a patient as a whole. It doesn't mean the oncologist think it's not my issue. The cardiologist will lead, and cardiologist, the fellows, PGs, and even they don't bother about the history. If they will emphasize on the history, a lot of things will be in front of them. So this is ESMO algorithm we need to follow. This algorithm should be displayed on each clinic. They should think about the left ventricular ejection fraction. These are actually recommendations, evidence-based level recommendations, level 1 and 2. So these are the randomized trials. They at the end, they follow all these guidelines. So we need to think about the left ventricular ejection fraction, either in the less than 50% or more than 50%, when we should start the chemotherapy, when we should start the stop the chemotherapy, or we should add alternative agents. So these all things already has been discussed by the Madam Professor Bakai and Madam Nante. So I just give a highlight over this. We need to select the patient, we need to categorize the patient regarding the cardio-oncological evaluation. We need to label the patient whether either it's in categorized in high risk, medium or low risk, then accordingly. So it's a dire need of multidisciplinary team required to make a plan, to follow the plan and to end the treatment and then keep on the surveillance. So these are the cardio-oncological evaluation points already has been discussed. So I don't want to make more my time in such a slides. So this is just a thorough description that we need to do clinical consultation, including blood pressure measurement, ECG, blood glucose, lipid profile, GFR, cardiovascular global risk assessment using guidelines, and we should apply the transthoracic echocardiography for measurement of left ventricular ejection fraction if it is available, otherwise two-dimensional Simpson biplane and GLS methods. Then we need to do left ventricular contrast agents could be potentially useful in two-dimensional echocardiography. CMR is recommended if the quality of TT is suboptimal. Use the same imaging modality for the monitoring as you people are doing or start at the basic level. So must monitor with these with same parameters, with same evaluation tests. Actively manage modifiable cardiovascular risk factor in the disease, encourage exercise on a regular basis, and healthy dietary habits. So this is just an algorithm with the anthracycline. An anthracycline group of drugs are doxorubicin, apirubicin, idarubicin, daunorubicin, and mitoxantrone. So I will not go in detail when and where you should start with the troponin, because these are in detailed guidelines. So if I will talk, the whole day will be spent in such guidelines. So again, guidelines says regarding the HER2, these are the monoclonal antibodies, like others are tyrosine kinase inhibitors, and they are associated with the occurrence of left ventricular dysfunction and leads to the heart failure. The monitoring strategies proposed by the current guidelines, I will show you in table. Briefly, all the guidelines recommend a cardiological assessment before starting HER2 initiation treatment, including a physical examination, ECG, and a transthoracic echocardiogram. And there are some important initial and subsequent evaluations of cardiac biomarkers, pre-therapeutic introduction of angiotensin converting enzyme inhibitors and receptor blockers, beta blockers. For the high-risk patients, we need to start at earlier treatment of the oncology. So this is all about the HER2 inhibitors when we use, where need to we evaluate, at what time, every 3 months during treatment we need to start, and we need to take up oncologist and cardiologist with the board, and we need to keep in consultation with the cardiologist during the oncology treatment. So I will not go in detail of the VEGF inhibitors. They also leads to the hypertension, myocardial ischemia, prolongation of QT interval, arterial thromboembolic disease. Actually, these are the targeted therapies of the mTOR VEGF. These are the sunitinib, sorafenib. Multiple drugs are used in the multiple malignant diseases, even the renal cell carcinoma, everolimus. So these are actually very costly drugs, and our Pakistan country, you know, the financial issues, but the Baitul Mal providing the opportunity to patients, they also avail such a big things from the Baitul Mal support. So currently many patients are even on the VEGF and TKS treatments. BCR ABL kinase inhibitors, what the guidelines say, actually BCR and ABL kinase. These are the two mutations over the genes located on the chromosome 9 and 22. So again, when we use the imatinib, dasatinib, nalotinib, and lot of other beautiful names of the chemotherapy targeted agents, and they are associated with the accelerated atherosclerosis, peripheral artery disease development, acute coronary syndrome, stroke, hypertension. The same things is in routine of the ischemic heart disease. Our cardiovascular cardiologists are observing with the same things. They are just aggravating with the normal person when they receive the chemotherapy. Hypercholesterolemia, pericardial effusion, pulmonary arterial hypertension, QTc prolongation. And what medical treatment we need to talk about this? We have to develop strategies for prevention of cardiotoxicity, identifying patients with a high cardiac risk, modifying lifestyle to decrease cardiac risk, using less cardiotoxic regimes if possible, and the use of Dexarone in metastatic patients requiring the chemotherapy, and those that should be should be more than 300 or less than more than 540. So in spite of doxorubicin, we can use other anthracyclines for the safe treatment of the patients. And we can start the prophylactic SE inhibitors, beta blockers, and angiotensin receptor blockers. So again, we need to follow the ESMO algorithm for cardiotoxic agents. These are the levels of evidence and conclusion. So come to the point. Cardiotoxicity has emerged as a frequent problem in the oncology. Cardiac events can be early or late onset anthracycline causing irreversible damage and should be avoided in patients at high cardiac risk. With the targeted therapies, cardiac events generally happens during treatment and can be reversible. So this keep in mind when should stop the treatment. And VGF TKIs induced hypertension mediated cardiotoxicity, thus hypertension management is paramount. One should always be attentive to promptly diagnose and treat ICR-related myocarditis. Thorough cardiac risk assessment should take place prior to any cancer treatment. Prompt diagnosis and treatment are required to avoid bad prognosis of heart failure. Late valvular disease should be considered in patients previously exposed to radiotherapy. Close collaboration with cardiologists is fundamental. So, key message, improvement in cancer therapies has resulted in long-term survivors who may be at risk of cardiotoxicity. Individuals with heart disease may develop cancer and require potentially cardiotoxic therapies. Close collaboration among health physicians is needed in order to provide the best cancer care while optimizing cardiovascular health. The establishment of cardio-oncology clinics programs provide the framework for optimizing clinical care delivery, education, research, and promotion of survivorship. So this is all about the cardiovascular toxicity, and बहुत बहुत शुक्रिया आप सब लोगों का कि आपने इस प्लेटफॉर्म पे मुझे दावत दी एंड मैंने कोशिश की अपना मैसेज कन्वे करने की. Thank you so much, all of you. So I'm here for further discussion.
Thank you so much, Dr. Iram. That was a wonderful presentation. What we call ke darya ko kuze mein band karna. It is not easy to translate. It essentially means that in a very small vessel, you're going to fit a whole river, and it is not easy in the field of nuclear medicine to be able to do that, and the evolving pharmacotherapy that has now come in for cancers, a wide spectrum, fantastic names that we have trouble actually keeping up with. So fascinating talk, and I'm sure you can we can talk about it all day. Thank you so much, my esteemed speakers. I will now move towards the panel sitting at the Pakistan Cardiac Society meeting room. The entire council is sitting there, and our panelists are there as well. So I would like very much to now invite Professor Haroon Babar for his comments. I would also like to reiterate here that we would like to wind up the 2 o'clock. So if we keep our comments and questions limited, but of course interesting. Professor Haroon Babar.
Yes, good afternoon, Dr. Amber.
Nice to hear you, Haroon. Kindly unmute.
Hear me?
Yes, now we can. Yes.
Yes, thank you very much, Dr. Amber, for inviting me here. These days, I am working here in at Mayo Hospital Cardiology Department, as you know, as Professor of Cardiology.
Yes, that's nice to
And
know.
it was really wonderful to hear all the presenters, and we learned a lot of our relationship with oncology. And I think this is a slightly neglected field here, which we come across. We are cardiologists, but definitely we are not doing what we should do in this respect, especially seeing the oncology patients. So this was a type of what I will say is a light thrown and like a beacon light for us. And I would congratulate all the speakers, especially Dr. Biljana, the way she represented the community which suffers from the side effects of chemotherapy, and they go on to land with the complications. On the one hand, we are trying to save the patients from malignancy and its effects. And on the other hand, we are exposing them to the cardiotoxic side effects of the drugs which they receive. So the message which I got, or my colleagues might have got, is that we should all be very careful in the assessment of the patients who come to us for our views or for our opinion, who are receiving chemotherapy. We should estimate their risk factors. We should be very careful in deciding very early, because the chemotherapy, as it was pointed out, that there might be asymptomatic. The patient might be asymptomatic and still his myocardium is at risk. And so the main point is to catch them before they go on to develop cardiac failure, overt cardiac failure, or they go on to develop ejection fraction less than 50%. So there are biomarkers which one of our esteemed guests and the speaker pointed out, the biomarkers as well as the imaging field. And if they're both combined early, and as biomarkers, as we all know that troponin T and BNP, they show you the damage being done. And if they are done early, we can catch these patients before they go on to develop irreversible damage. The other thing is inflammatory markers, like interleukin-6, like CRP, like myeloperoxidases. And these are also being looked after, and they should also, I think, be on the list to see, because they also point out the damage, either it is functional in the heart. So these should also be counted on. The other thing which I want to point out is that the imaging modality like echo, which is very freely available to us, it should be done on periodic basis. It should be done soon when the patients, before the patient starts chemo, like drugs like anthracyclines, and then it should be followed up, I think, once the chemo finishes, and then every 3 months, because that will show you the patient at risk who might develop the side effects after a long time, say after 1 year, or say after more than 1 year. And the literature has shown that the side effects may come after 20 to 30 years later. So these are the patients who need follow-up, patients who have survived the chemo and the effects of the malignancy. So I think this is very important.
Yes.
And the other thing which I would like to point out is, as one of our speakers pointed out, the the imaging quality of MR. And MR is being used as, I think, being underused in our society here, in our country here, maybe because the lack of the availability. But some big centers, they are equipped with this modality, and it should be freely used whenever there is some doubt in your echo findings or whenever you are unable to comprehend what is going on in an asymptomatic patient. Thank you very much.
Thank you, Professor Haroon, for your comprehensive comments. And I think if I may just put a few questions to the speaker, because I think must have been burning questions from the participants as well. Because your markers that we were talking about, I would say that we always check them all the time. But what level of troponin I or NT-proBNP you are looking at, which you think is abnormal, because, or what levels of up and down that you will look at? If any one of the speakers would like to take that, I would like you to keep your comments short to less than 2 minutes or 1 minute. Does any one of the speakers wish to take that question? Because it's, I think, an important question. We are constantly called to evaluate people in the ICUs and with and medical wards that they have a raised troponin I. So what are we looking at?
Let's ask Lubna Bekai. She especially had this
Let's
point.
ask Lubna Bekai for that. Yeah. Yes. Lubna Bekai? Yeah, for the cardiac marker. If you can clarify, what level of troponin I are we looking at? Or are you looking at a rise and fall? This is myocardial injury, right? But not necessarily an infarct or ischemic event.
Lubna Bekai, you need to unmute yourself before you answer. Can you hear us, Lubna Bekai? I think she can't hear us. Biljana, would you like to take up this challenge in question? That, you know, I've got cardiac toxicity going on, what kind of cardiac markers and the elevations?
What level?
One thing, I think that we should actually, to just relate to a comment that was previously mentioned, I think that we should start, when we evaluate our patients for whether they should accept some kind of treatment or not, we have to understand that all these people are accepting everything for life-saving treatment. So we have to weigh out somehow the risks with the benefits. On the other side, we are not, though, to understand that we're living in the era of shared decision-making. If maybe 2 weeks of extension of some good capacities for us, something not meaningful, but maybe for someone who wants to see his children, grandchildren fly over from someplace and have at least a dinner with them, it's immense. So that is one thing. I think that we should start making, from the organizational point of view, because we're all in different leadership positions here, I think we should start somehow matching the charts we're having in oncology, who's going to get what, and start to extrapolate whether we're going to need extra slots in our beds for these people who will need some hospitalization after chemo. And to finally come to the question of biomarkers, I think we are also sometimes overdiagnosing. First of all, we don't know if that patient, there is rarely a patient with cancer who doesn't have a kidney problem. We all know that troponin levels are highly dependent on kidney function. You load someone with contrast and there all of a sudden their eGFR plummets instead of staying steady in some 40s or 50%. So I think that we have to be very careful with the biomarkers. Also, yes, it's good if someone is paying for them and not asking how much use we had in the long term. But I think that in all our very blessed state-covered insurances where everyone is insured, we are still not giving anyone any explanation why we're doing something. But if we are going to start living, and sadly we will all start going to have the almost the pre-authorization like the United States has, we'll have to justify why we're drawing blood for gazillion times for troponins or BNPs or NT-proBNPs. Personally, in our own lab, every day I check in our electronic health record system, both BNP, NT-proBNP, not because I think I need both, but because I don't know which kit our lab is going to have available on that day. So it's a very hard decision. I'm going to leave with Dr. Bekai if she wants to put the cutoff. For me, the cutoff is highly variable for these group of patients, and I am not sure. And I have recently reviewed a lot of literature for so-called normal levels of BNP, NT-proBNP, and troponins, but for another population of patients, I am not sure that we have available data that are telling us what is the normal value for a cancer patient. So if
Yeah.
someone has a better level of evidence to correct me, please do.
It's a difficult
So far,
question.
yeah. Yes, Professor
Dr. Mack?
Manik, so far, I've not seen anything in the literature that I've read with regard to the exact level of the natriuretic peptides and the cardiac troponins. All they're saying is that if there is a significant rise in the cardiac troponins, so I think this is a rise and fall, which is similar to what we see in patients with myocardial infarction. So if you have already ruled out that this patient is not having myocardial infarction, and you suddenly have a significant rise in the cardiac troponins, this may be an early marker of cardiotoxicity. So it's really more of a surveillance thing in order to identify which patients might be having complications with chemotherapy. I'm not sure if Professor Bakay has seen more information about that, but with the literature I saw, I didn't see actually also a level of troponin that's considered to be diagnostic for cardiotoxicity, but just more of a significant rise in the cardiac troponins.
I
That's
agree
true,
with Dr. Neneti. May I say something? I'm agree
Yes,
with Dr.
yes.
Neneti. If we have the elevated levels in the first reading, we must have to follow these cardiac enzymes for the rise and the fall, and must be combined with the imaging modality. As we can identify that the strain can peak very early before the decrease in the LVF. If the both correlate simultaneously, that we can predict it's because of the cardiotoxicity. As we all know that the many of the causes of the release of the cardiac troponins from the kidney, acute kidney failures, from the anemia, from the high demand supply mismatch can also cause a release in the cardiac troponins. That must be the comprehensive approach, symptoms, biomarkers, and the cardiac imaging. All must be combined together to make a final decision, whether it's related to the cardiotoxicity or something else, and can stop or need to follow these patients.
Right. I think thank you very much. And if we can,
Can I make a comment
yes,
about
please,
the
Dr.
BNP levels? You see,
Please.
as far as the BNP
Just a
levels
second, sir.
are-
And after that, Dr. Ahmed Masood has his hand raised also.
yeah.
you see the BNP level, which is normal, is less than 35, and the anti-proBNP is 125. This
Yes.
is for chronic conditions. And if there is an acute failure, the extent for the anti-proBNP is 5,000. And for the chronic conditions, the BNP, the level is 125. Now, the important point which I would like to emphasize is that when we are doing an ejection fraction, what we need to understand is that we should have a baseline at that level. You want to see the ejection fraction, you want to see the strain imaging, and then follow it. And as soon as you have a subclinical evidence that there is failure coming up, you start with the guideline treated medical therapy for heart failure, and you can protect them because you would like to continue with the treatment. So I think these are important points that we have to keep in mind.
You see, my problem is
another important thing is that cancer and cardiovascular diseases, they have things in like they have position, they have obesity, they have high cholesterol gives rise to breast cancer, and you have all the risk factors for cardiovascular diseases which combine with cancer. And the other thing is that once you have treated the cancer patient or those who are cancer survivors, when they get older, it is not because the drugs had the effect upon the myocardium that these patients start developing cardiovascular disease. It is because of the age-related factors that they are going to die of cardiovascular diseases. So then you need to actually institute the lifestyle changes in these patients. So I think what we need to do is to have a consolidated cardio-oncology services. And in Pakistan, at the moment, you have so many nuclear centers all over Pakistan but I'm not sure. And I think I would like Dr. Dubna to tell me if they have registries for that and what is the data which is available and how they are treating them and how they are following them up, because that is important. That is what is needed at the time. And I think for that purpose, this webinar is a very, very timely thought that has come up.
Dr. Ahmed Masood, you have a comment? Kindly unmute and ask because we were going to wind up in another 5 minutes.
Yes, I have a comment that when we don't have cutoff values for troponin I in such patients, we can use the cutoff values for every kit that assays troponin I, and any persistent rise in troponin I, then that patient should be taken as at high risk, and imaging should be done more frequently as long as we don't have a specific data for such patients. This was my comment on.
Okay, great. Thank you. I think my problem is that if you have a raised troponin, will you do a coronary angiogram to look for skin?
Dr. Amber, could I make a little comment, please?
Yes.
You know, we have a very huge cardiology department, and not a huge department, a very active one in the Fauci Foundation, and an oncology department also. And we get a stream of referrals. And I think one of the very basic thing which one needs is a good echo machine. I found that people tend not to calculate the ejection fraction properly. You know, so cardiologists need to be focused that they have the right machines and right tools to work out the ejection fraction. We get regular referrals of patients who had fall in ejection fraction, and we have very low threshold for doing coronary angiogram and LV SIN on these guys, on these ladies basically. And people come with troponin, with chest pains. And the moment they come with that, we do a cath and we follow them with the LV SIN, and we found that most of the time what an echocardiogram thought was a falling ejection fraction had a good ejection fraction. So there's not a lot of uniformity in the echocardiogram which is given across in this service. And those people who had troponin change, if they had a very typical chest pain and we did angiogram, we found that the EF was fine, but they had underlying coronary artery disease. And there's quite a number of patients in our follow-up now who undergoing chemotherapy after undergoing stenting, and they are and they're still the program, and we follow them very regularly. We are hoping to collect this data and to publish it soon. So having a troponin would suggest an underlying coronary artery disease to us. That's been our experience in last 1 year. Another thing which I think I'd like to suggest to the international faculty sitting here, that there is a discrepancy in how people respond in different races to the anti-chemotherapy drugs. Like our oncologists here refuse to give them the big bolus every 3 weeks or 6 weeks, whichever the protocol is, and they split up this bolus in between. And they think that whenever we give them the full bolus, our people, our race at least finds it very difficult to go through and complete the whole cycles. And when they split up the dosage, because for them, it's the total dosage is important for the oncology response and not just the bolus to give. So if you split the dosage up, patients tend to tolerate this much better, and the outcome is much better. And I think I love Dr. Lubna's response initially when she said that we don't want patients of oncology today to be ending up with a bad LV later in life. So that's a real very apt statement. And most of the oncology departments I've seen are using computers to work out the dosages, the regimens, the dates and all. And they're actually very well geared to collect data and publish. And I wish they would publish this data because, in cardiology, we had the largest spending of any other field of medicine for 10 years. And for the last 3 years, I think now oncology has overtaken cardiology as the most spended, the field of the future. So I think for anybody, we should not have we should have a little threshold for doing an angiogram. If you suspect there's a fall in LV, and try and find out what the reason is, like we do a cath for anybody who's falling LV in oncology and trying to see the coronary arteries, and especially if there's a troponin change, don't be hesitant in following up an angiogram and maybe ending up with a stenting. And you stent them regularly, and don't you make them miss their oncology session or the cycles.
Great comment, General Suhail. This is what I was asking and looking for as an answer as I sent these questions across. There are some more comments and questions coming up, but I think we'll have to wind up. It's 2 o'clock, and I would now like to ask Professor Bilal to finalize this webinar. I would also like to, on my end, thank Professor Khalda Sumro, who's the leading beacon of light in this fantastic series of webinars that she's been hosting. She's collecting all these galaxies of stars and people from international faculties who are joining us, and we're truly honored to meet them and talk to them and have this great opportunity to learn from them. And so I would like to thank you and thank you for the honor of asking me onto this webinar. I would like to hand over to Professor Bilal to wind up, and if you would like the rest of the panelists or just wind up on their behalf.
Thank you, Professor Amber. It's indeed an honor and a privilege. Thank you, Professor Khalda. And since it was a go red, I thought all I can do is wear a red tie and try and make it part of the whole thing. Biljara, you really made us quite scared with your presentation, where in your slide you had that paclitaxel thing coming up over there and showing us that it's a bradycardia thing. We have placed in a lot of these paclitaxel coated stents, and we really wonder now, getting back to it, what kind of an oncology issues that are being created by us also. So for everyone over here, it is high time that we start going into it. The first thing ever in any scientific growth is the realization of a need. And once you have that realization established, then the whole question of coming up with the sequence of developing the human resource and the physical resources starts coming up. In our part of the world, yes, our system is also heavily funded by the government, but being a third world country, we are quite strongly challenged. And a lot of our oncology centers do not have enough cardiologists, etc., on board all the time. So these are the things that sort of need to be done. The troponin I question has been very well been addressed, and it doesn't need any further addressing. So all I'll say is that thank you, Biljana, and it shows that this world has now gradually become a global village. Really, you are sitting all the way in Serbia, Professor Ray is sitting all the way in Philippines, and a wide array of people are sitting all across the country. We have got nearly 100-odd participants for this conference, this meeting today. So this just shows the interest and the acceptance of the fact that the things are on the move. The heart failure is there. And we know that once, God forbid, heart failure sets in, you are going to die of it. 50% are lost within 5 years. And if our oncology treatment is one of the causative reasons behind it, this needs to be addressed. As they have said, everyone repeatedly, that we need to do it, but then research and guidelines take time to be developed. Medications are there, but we have to accept the fact. We probably also will have to look at the fact that the early diagnosis is probably the answer, when how strong the treatment has to be may be curtailed. But these are all the questions and things that will only time will guide us, and which kind of medicines that we can easily consume, and which kind of things that Dr. Iram tomorrow will be coming up from the oncology section at the nuclear centers, looking into these things. So as part of the effort that Pakistan Cardiac Society, the Go Red Woman, we are going to be having our next cardiac congress from 18th, 19th, and on 18th, 19th, and 20th in Peshawar. Our convener of the congress is here, and I'm going to be requesting Professor Mahmood that we must have a session on both the women issues and the oncology issues. Professor Ashraf is also sitting over here with us. Tariq Ashraf, he's the chief editor of the Pakistan Cardiac Society's journal, the Pakistan Heart Journal, which has now risen to a higher level as it's being accepted at a higher level for the research purposes in the nation. So if those people who have got standardized research regarding cardiac and oncology, I'll be requesting him that he should give them a step ahead rather than keeping them at a line below. And this way, these people will have a reason to work higher in these sites. We must make our efforts in order to improve our diagnostic services, for which, of course, we will need the hardware as well as the human resource. And having the hardware is of no benefit unless the human resource does not exist. And with these remarks, I'll say, Biljana, Ray, and Iram and Lubna, so very kind of you for sparing your Sunday for this task. Hope you have a lovely day. And inshallah, all God willing, we'll meet physically very soon. Take care. Allah Hafiz.
Thank you very much.
Thanks a lot.
And must also thank Dr. Khalda for her fabulous efforts. And I think since Professor Amber has already said, but the house sitting over here, about 10 people, they are especially want to stand up and say thank you to her and for her big efforts over here.
He deserves a standing ovation every time.
I would like to give a big hand as we can for a minute and say thank you to her in person.
Thank you.
Hats off to Professor Khalda.
Stay safe.
Allah Hafiz.
Allah Hafiz.
Allah Hafiz.
Next.